Please subscribe, share, and like my videos.
Goes back because of excessive AUA for So how many of you have scrubbed in on a retroperitoneal node dissection for testis cancer? How many? Anyone? Okay, so raise your hand, John, I'm just curious. So you can see how this is a difficult disease to talk about, and I'm going to give you a little bit of the North American thought process regarding how we integrate surgery for non-seminomatous germ cell tumor of the testis. This was one of the hardest diseases I thought to understand during residency because of the totipotential nature of the testis and the various permutations and combinations that happen with testicular cancer. Now, as you know, this is the most common malignancy in men. In the US, there are about 8,000 new cases and 400 deaths. And with the advent of platinum-based chemotherapy, we've converted a disease that was lethal to a highly curable disease. However, still, with overall survival rates still in somewhere ranged in the 80 to 90%, depending on the stage. So the retroperitoneal node dissection was first described in the 1900s by a French surgeon named Cugnot. That was the first report. But then in World War II, where they saw a lot of young men in the US military at Walter Reed, they began to realize that an RPLND actually would potentially be curative, even in the pre-chemotherapy era. And the reason for this is because testis cancer, unlike other malignancies, has a very predictable pattern of lymphatic spread, and that pattern is common to all of the histologic subtypes. So I'm going to talk about the role of RPLND in stage 1 as primary therapy, how we integrate surgery for stage 2 disease, and then finally, what is the role of post-chemotherapy surgery? So, what are the treatment options for stage 1? What is stage 1? Right, so no evidence of retroperitoneal involvement, and what else? I can't hear. One more thing.
No lymph nodes, no distant nets.
No markers, right? So no evidence of recurrence either by biomarkers and no radiographic evidence of disease. And the treatment options include surveillance, giving them 2 courses of chemotherapy, or retroperitoneal dissection. And what's important to recognize is all of these patients universally are going to do well, and the survival rate is nearly 100% for all of them. And so how do we try to stratify patients in one of those 2? So what is the rationale for surveillance? Orchiectomy alone cures 80% of patients with stage 1 disease. And obviously, if you survey them, you avoid surgery and chemotherapy, and the survival rates for recurrence remain equivalent. What are the requirements for surveillance? And I think this is very important in this part of the world. Patient compliance is extremely important. Most recurrences will occur within the first 6 months, and then the vast majority of recurrences will occur in the first 2 years. However, there are reports of recurrences of greater than 5 years. So you need a compliant patient. Remember, these are young patients who are not necessarily the most compliant patient group. And you need to have access to CT imaging on an easy and routine basis. So here are the surveillance data for multiple studies. And you can see the relapse rate is somewhere around 30% across the board looking at these various studies, although survival rate is extremely high. So in general, board question, about 30% of patients across the board with stage 1 on surveillance are going to recur. So is there anything we can do to stratify these patients better to try to predict who will recur and who can safely be observed or have a higher chance of not getting a recurrence? So these are some risk-adapted strategies. So if you look at factors that include lymphovascular invasion in the primary orchiectomy specimen, the presence of embryonal carcinoma in the specimen, and studies have looked at different percentages, more than 50%, more than 80, etc. But in general, just remember more embryonal. and then advanced T stage at the orchiectomy specimen, T2 or T4. Here's what happens if you stratify this according to risk. So if these patients have none of those risk factors, they're low risk. If they have one, they're intermediate, and then if they have two or more of those, they're high. And you can see, so if you have none of those three risk factors that we talked about, your chance for recurrence is 0 to 20%. One risk factor is 25 to 50, and then two or more, the chance that you will develop a retroperitoneal recurrence is almost 80%. Suggesting that these are the patients that probably should go on to have surgery. Now, the other question is, what is stage 1? So how do you define stage 1? Remember, what is an abnormal lymph node based on CT standards, CT criteria? More than one size. You scratched your head, so you raised your hand in reverse as you have the answer. How big? When you get a CT report that says lymphadenopathy, what does that mean?
More than 2 centimeters.
1 centimeter, right? So the CT in general diagnostic criteria is 1 centimeter. So if you've got someone who's reading these scans, a radiologist, who is not familiar with testis cancer, any node over less than 1 centimeter will be read as normal. That's why it's extremely important to look at the films yourself. If you look at sensitivity and specificity based on lymph node size, anywhere from 4 to 10, as you go down in lymph node size, obviously your sensitivity is going to increase and your specificity is going to decrease. But there's a sweet spot somewhere around 5 to 6 millimeters where you will increase your specificity and not have too much of a compromise on sensitivity. So we consider, so a node like this for us, if it's in the same landing zone, is the same size as the testis, and it's over 5 to 6 millimeters, we would not consider that stage 1. So that would be considered an abnormal node. And that's really important. And that was not incorporated in some of the earlier studies, which explains why the recurrence rates are probably higher. So the advantages of retroperitoneal node dissection over chemotherapy in this setting is the survival rate is extremely high. You get accurate pathological staging. There will be 60 to 70% of patients with negative nodes, and then therefore you will avoid unnecessary chemotherapy exposure. And we also sterilized the retroperitoneum. If you do a good node dissection, those patients need a baseline CT, but afterwards in surveillance, they require no further abdominal imaging. They only need their chests imaged. Most recurrences are early within the first year, and late recurrences can then get chemotherapy. We also eradicate teratoma. 20% of the time you'll find teratoma in the specimen, which is not chemosensitive, potentially leading to the requirement for surgery even after you give chemotherapy. As well as the fact that in patients who have low volume disease, so if you have less than 2 nodes positive, if you don't have extracapsular extension, if you have no nerve involvement, those patients do not need chemotherapy after surgery. The other thing to recognize is chemotherapy is not benign. Remember, this is a young population. They have a long life ahead of them with a higher risk of developing long-term complications. So there is a higher risk of cardiovascular disease in patients who receive platinum, 1.4 to 7 times increased risk of the normal population. There's a 2-fold chance that you develop a secondary malignancy, usually some form of hematologic malignancies. And these risks are similar to smoking, actually. So getting platinum is not benign. And you also have the secondary complications of chemotherapy, Raynaud's, neuropathy, autotoxicity, etc. In expert hands, the complication rates are relatively low, which the biggest issue is, of course, ejaculatory discomfort, ejaculatory dysfunction. These are the sympathetic chains, and these are the chains that we attempt to spare during surgery. And templates are also devised in order to spare at least one side of the sympathetic chain. This is an example of one of my cases. So here's the IVC, here is the aorta, and then here is a sympathetic chain preserved around these white vessel loops. So in terms of stage 1, you need to risk stratify your patients. Most of these patients will do fine on observation. And then higher risk patients, potentially either surgery or chemotherapy. All right, so what about stage 2? So what is stage 2? Anyone? Stage 2?
Lymph node
Yeah?
It's then 5.
Okay, what about visceral involvement? No. So no visceral involvement, just adenopathy. Anyone who has elevated markers, anyone who has greater than PT2 disease, that is adenopathy that is more than 3 centimeters, anyone that has multifocal disease, so lymph nodes that are outside the landing zone, or if you have back pain, because back pain suggests extracapsular nodal extension. All of these patients get induction chemotherapy regardless, so they're not candidates for surgery. Patients who have normal markers and have low volume disease, so less than 3 centimeters, with nodes confined to the landing zone of the ipsilateral testis. If you operate on those, 2/3 of those patients will avoid chemotherapy. So you may be able to keep 66% of those without chemotherapy. In the post-chemotherapy setting, it's extremely important to resect residual tumor. And the reasons for this are teratoma, which is chemo-resistant, resection becomes curative, and there is a potential for malignant transformation, which is lethal, and late relapses. Most of the studies that looked at chemotherapy alone were flawed by short follow-up. The median relapse time for teratoma is 5 to 7 years. You have to follow these patients long enough for them to recur. The other thing is that a certain percentage of patients after chemotherapy will still have viable germ cell tumor. And in this study that looked at surgery after getting chemotherapy, in a multivariate analysis of complete resection, as well as proportion of viable cancer cells, predicted outcome. And a complete resection for viable germ cell tumor may be curative, and it's also prognostic. Remember, just biologically, if you give chemotherapy and you still have viable cancer cells, those lesions, those cells, by definition, are chemo-resistant. At the same time, when we operate and you find necrosis, that is, you've had a complete response with chemotherapy, you have not done that patient any favors. So how can we accurately predict those patients with necrosis and minimize the morbidity of surgery? So what is a residual mass after chemotherapy? So here's an intra-aortochemo node, okay? Pre-chemo. Here's this node now, post-chemo, which measures probably about 2 millimeters or so. Is that a complete response? Is that still a persistent node? How do you decide what to do? And the problem is that historically, accurately predicting the histology of post-chemotherapy residual masses is not easy. Numerous institutions have tried to come up with prognostic or predictive factors where one could predict whether there was necrosis in the specimen, teratoma, or viable cancer, and they've used multiple different criteria. So, for example, less than 10 millimeter node, or a greater than 70% reduction in size after chemotherapy with no teratoma in the primary specimen, prediction models, or a mass less than a centimeter with no teratoma in the primary, or pre-chemotherapy size of less than 3 centimeters. Anyways, various predictive factors, very, very difficult. No matter what you used, you could not really predict who was going to have necrosis, who would have teratoma, and who would have viable germ cell tumor. When you zero it down to then even post-chemotherapy small masses, so less than 2 centimeters or no masses at all, you still had about a 7% chance of finding viable germ cell tumor in the final post-surgical specimen, and about a 20 to 30% chance of finding teratoma. Let's zero it down even further. So between 1.5 to 2 centimeters, 1 to 1.5, 0 to 1, and no mass, you're still finding teratoma in somewhere between 20 to 30% of the specimen. If you looked at teratoma as well as the size of these masses that are very, very small, you develop a little bit of a predictive value. So univariate analysis absence of teratoma in the primary, and a normal pre-chemotherapy AFP were predictive of having necrosis in the retroperitoneum. Another trial looked at 87 patients who had an excellent response to chemotherapy, small lesions afterwards, all had a retroperitoneal node dissection, and similarly, there was an increasing incidence of teratoma within the size of the mass, but no significant pre or post-chemotherapy factor could predict necrosis. And if you use the decision analysis tree, if you resected every mass that was between 1 and 2 centimeters, you got a survival advantage of about 2 years. If you use a cutoff of 0 to 1 centimeter, the survival advantage was about 1 year. So what to do with post-chemotherapy masses? Just remember the overall incidence of residual disease is 44%. Incidence of teratoma is 36%. And viable cancer, still going to be somewhere around 5%. Even in small masses, it's still 35%. The absence of teratoma in the primary, normal pre-chemotherapy AFP are predictive of necrosis in the retroperitoneum. If you observe these patients, you have to counsel your patient that there is about a 5% chance that they're going to recur in 4 years, and that will probably be higher if you follow those patients longer. The extent of the resection is also important. So I get many times patients refer to me, they've had a single solitary post-chemotherapy mass. And the thought is that we should go and just remove the mass and not do a full bilateral retroperitoneal node dissection. If you do that, you will miss 7 to 32% of disease because that disease will fall outside of the initial template. And this has been shown in multiple studies, multiple institutions. Anyone, at least in the US, who has post-chemotherapy RPLND gets a full bilateral dissection, so we don't miss extratemporal disease. Finally, what about the worst of the worst? Patients who've had salvage chemotherapy, gotten chemotherapy, failed, gone on to second-line chemotherapy. Largest studies came out of Indiana. If you look at patients who get just induction chemo, like I said, 5 to 10% viable cancer rate. Patients who have salvage chemotherapy and their markers go down, 55% viable cancer rate. So those patients, a huge percentage of them, will still have viable cancer, even if their markers go to normal. In those that were completely resected, 82% did not have adjuvant chemotherapy and were NED. 36% had adjuvant chemotherapy and were NED. All of the ones that had an incomplete resection died. So the role of surgery in the salvage setting is very, very different. Those patients all have to have a very good operation. If you leave cancer behind or you leave lesions behind, the survival rate will be very, very poor. So it's imperative to resect all post-salvage chemomasses, and you need to attempt complete resection because getting chemotherapy after that does not appear to help, as they tend to be the worst of the worst. Here are some surgical examples. So here's an example of a post-chemotherapy with, you can see here, there's actually teratoma in the renal vein, large lesion wrapped around, and this is some of the disease that we see post-chemotherapy with a good team and careful dissection. You can still safely remove all of the disease. So here's the renal vein. Here's the interaortic cable space with everything being resected. What about desperation surgery? That means they've gotten chemotherapy and their markers are still high. You do know that those patients are not going to do poorly. However, there are some prognostic variables that may predict a better response. If you just have one lesion, one solitary node, they have a much better outcome. Elevated AFP appears to be better prognosis than if you have elevated beta HCG. And then if you have retroperitoneal disease versus visceral disease, they appear to do better. 63 patients from MD Anderson who underwent desperation surgery. Most of them had a complete resection, and you could salvage about half of them, even in the setting of an elevated one. So, in conclusion, Retroperitoneal dissection remains an essential component to the cure of testicular cancer, and it's not just chemotherapy. If you fail to eradicate all retroperitoneal disease, you may get late relapses. Remember, this is a young population. And in experienced hands, it's associated with minimal short and long-term morbidity. Questions?
If we have two residual mass, one in the retroperitoneal and one in the abdominal, what do we do?
So-
We shift all?
Yeah. So residual masses. So residual masses in the chest usually are teratoma in the setting of negative minor, and it will resect everything. So you resect all visible residual disease, usually in a staged fashion. So usually resect usually resect the chest, the retroperitoneum first, and then they'll go and resect the chest. Questions? Okay, thank you very much. Thank you very much.
شكرا دكتور وليد. هو قريب من الموضوع. أي حد يسأل أي سؤال؟ شكرا. بريك